Welcome to the Beyond Pain podcast with your host, Joe Gambino and Joe LaVacca. Join the two Joes, two physical therapists, as they discuss how to navigate the uncertainties of pain so you can move beyond it and get back to the activities you love most. This podcast is for Joe, and their guests to share their clinical thoughts and ideas based on their collective clinical experiences. Can this information be for you? Maybe, but we cannot know for sure. Therefore, it is always worth talking to your healthcare provider to make the best decisions in your care before you implement anything on this podcast. And please use common sense. Welcome back into the Beyond Pain podcast. I am one of your hosts, Joe Gambino. I'm here with our other host, Joe LaVacca. This podcast can be found on Instagram, Beyond Pain Podcast, on YouTube, Cups of Joe _PT. And you can find both of us on Instagram at Joe Gambino DPT for myself, at Strength of Motion _PT for LaVacca. And we do have a guest today, Mr. Dan Pope. He is just a man off the street that we picked up today. And I will just leave him the floor to intro himself in and tell our listeners more about him.
Yeah, thanks for having me. It was very cold out there, and I'm glad to finally be inside with a roof over my head and a little bit of food. So I appreciate you picking me up today.
Yeah, it is probably pretty cold up in Mass, right? Because it's been freezing in New York. It's been absolutely a brutal start to, I guess we could call this spring, or is this like fake winter, or I don't know what this is.
So about a decade ago when I moved to Massachusetts, I took my expectations and just brought them extremely low. Usually during March, it's still winter, and then May, it's pretty much still winter, you know? So if we have any sort of warmth, and I'm like, yeah, awesome. But if it's terrible, I'm like, yeah, that's kind of how it goes. But yeah, it's been bad. We had snow this morning, had about an inch. So I don't know. It is what it is, right? I'm not in Canada. I have some friends in Canada, and it's way worse.
There's always a bright spot.
Yeah.
But I guess the weather thing, though, I mean, you probably had, you mentioned that you're from Colorado when we were just chatting before. The Colorado weather here, man, is like beautiful 99% of the time. And then you just get like 18 inches of snow out of nowhere, or a hailstorm for like 10 minutes out of nowhere. And then it just like goes back to being great. What was there another intermediate stop for you? I forget, because I remember you're from Colorado, beautiful weather. You had to lower your expectations, probably for other reasons, but we'll leave it at that with Massachusetts. You know, I'm sure they're all good people, even though they're Red Sox fans and Patriots fans and all that stuff. Was there another stop in between? I feel like there was one more stop, if I remember correctly, from your course.
So I'll throw a little wrench in there. I actually been born and raised in New Jersey until I was, I would say, mid to late 20s. And that's when I went to Colorado. And I went to Colorado because my wife got a residency out there. So I followed her out there, stayed for a few years, and then I moved to Massachusetts. But yeah, I spent the majority of my life in New Jersey, Southern New Jersey mostly, but basically been all over the place in Jersey. Southern New Jersey, Northern Jersey. I went to school at Rutgers, which is considered, Central Jersey. New Jersey's hilarious because it's a tiny state, but people identify strongly to certain areas, But yeah, that's kind of my background.
Yeah, I hear. Well, it's like the same thing with Long Island and Staten Island. I mean, I'm born and raised in Staten Island. Joe's over out there in Queens, but you have to represent the side of Queens, right? Joe, what are the wars? What are the neighborhoods in Queens that are rivals to each other? You're like, where do you want to be from Queens, and where do you not want to be from Queens?
It's not necessarily rivals, but Queens Boulevard, not Queens Boulevard. Astoria Boulevard kind of separates the two sides of Astoria in a sense. So you have one side where I was on, that was the better side, and then on the opposite side of that, it was just a little bit more residential. I mean, you have dip Mars and stuff where there's a lot of stuff to do, but anyone who lives over there thinks that's the better side. So it is what it is. I like to spend time on both sides. So
all right, very good. All right, well, Dan, we got a very important question that we have to ask everybody on the show, and that is, how do you take your coffee?
Black, usually, unless it's too hot. In that case, I'll put a little cream in there, but I'm addicted to caffeine. I've got a drug problem. Let's be honest here. I'm in it for the energy, but I love coffee, all types.
How many cups are you drinking a day?
I don't even know. I think it's tough because it depends on how big your mug is. I mean, I'll say I'll drink like 3 cups, but really it's probably like 72 ounces. You know what I mean? Depending on how big your cup is. So I'm not sure. I make a pot in the morning and I try to finish it. So
All right,
I've
very
got a
good. Now,
problem.
when you say hot, are you talking about like if it's too hot outside, you'll like try to cool down the coffee, or is it actually like
Temperature,
temperature
man. I'm
hot?
just
Like it's
trying to
just
get
like
that in my
too hot.
system.
All
So
right.
too hot. I got to cool it down with something. There's cream. It's going in there. Sometimes I'll put some water in there. I bet the coffee aficionados are like, this is a psychopath, but that's how I do it, I
I've
guess.
never heard of the water. The water's a new one, Joe. We gotta try that
Yeah,
one.
that's a new one. I don't know if I'm
Sometimes
gonna
just anything.
now. I would like if I had like a cold brew and I found it too strong, I would cut it with a little bit of water. That makes sense to me. But to cool it off a little bit, I feel like if you really enjoy the coffee, that I would just water it down. No,
I like both of it, but if it's too hot, it's going to burn my mouth. And if I want to be caffeinated, I got to do something.
you
You know
just
what I
can't
mean?
wait like the 2 more
I
minutes
can't
for
wait.
it to cool down.
I have zero patience, I guess.
Clock is
Yeah.
ticking. Clock is ticking. Man, oh God, that's really great, Dad. So, look, we got a lot of other questions for you. You'll be able to completely redeem yourself today and get everybody back on your side. But the other question that we like to start with is your past and mainly your injury past. This is something that you've been very open about, at least throughout the entire fitness pain-free certification, sharing your story. So for those who've never heard it, we were wondering or hoping if you could dive into that a little bit and maybe just share how it made you or shaped the clinician you are today.
Yeah, for sure. When you guys shot this question over prior to the podcast, I thought it was an interesting one. I hurt myself all the time. I'm currently hurt a little bit, it's funny in terms of my history, it's very long and extensive. And I guess the big thing is that as a physical therapist, it's helpful. It's helpful to hurt yourself because you can learn more about the injury, how it goes, and then help other people, right? It's like being any other sort of expert. You go through it yourself, you learn how to, and then I just am regularly trying to share that with other folks. And I think it helps. I think it really helps. It sucks, obviously. But yeah, very helpful. You want me to share specific examples or the recent ones, or what are your thoughts?
Yeah, sure. Why not? But whatever you think would be helpful or what maybe the most
Yeah,
current one that's you're
yeah.
battling, we could start there.
Go current or the most impactful. I'd say pick a lane there.
Well, one of the things that's been interesting lately, I'll say, is that my biggest background in any sort of sports or like physical activity has been strength training. And in strength training and also some running, there's a lot of overuse injuries and they're handled in a specific way, mostly tendinopathies, I'll say. More recently, don't ask me why I decided to do this, but I took up Brazilian Jiu-Jitsu, which is a lot of fun. I've been doing it a few years now, and there's a lot more ligamentous injuries. And I'll tell you what, that's a very different beast. And I was lucky when I played a lot of field sports and court sports growing up. I never had a major ligamentous injury, like an ACL tear, right? I did have some in terms of shoulder instability. But once I started jujitsu, I got a lot of ligamentous injuries. I dislocated my shoulder, high ankle sprain, LCL injury. And it's very different than the typical kind of slow pain comes on over the course of time. Then you have this nagging injury that you can kind of keep training through, but you have to be smart. When you have a major ligamentous injury, it almost like you have to pump the brakes immediately a lot, and you can't necessarily push through it quite as much. And sometimes it turns a corner a lot faster than, let's say, a tendinopathy. I think ankle sprains are a good example where you sprain your ankle and you can't walk on that thing. And sometimes that's for a week or two. And all of a sudden you're back to sport like 3 weeks later, which is nuts. And the same thing goes for like a shoulder dislocation. And I tell you what, that's not a good thing, I wouldn't say. I will say that for a lot of these ligamentous injuries, people go back way too fast. And I think the literature supports that, particularly with like a lateral ankle sprain, where folks like, this is hilarious, but I read this in a study from NCAA Division I athletes. The average return to sport time after a lateral ankle sprain is 1.5 days, which I think is consistent with what I see. People just like limp it off. They roll their ankle badly. They go back to playing, and there's like a 50% recurrence rate. It's like the highest recurrence rate of any orthopedic injury. So, what is neat about these is that they do turn the corner quickly. They're very devastating when they occur, and we probably need to do a better job of rehabbing those. But those have been interesting, and getting back to my activities has been a whole new learning experience for me. And I think this is one of the reasons, not to change the topic too much, but you kind of have to find a physical therapist that really understands the activities you want to get back to. So even for myself, a couple years ago, I really like wrestling and combat sports and jujitsu, but having done it for a few years now and hurt myself a few times, I understand it way better. I'm a much better physical therapist now because I'm actually doing the activity myself, and I've hurt myself a few more times. And I've also rehabbed a bunch of my friends that are now in the sport, and they enjoy it and I enjoy it, and it's just been really good. I know a lot of folks will say, I hate it when I get injured. It's the worst. I strained my calf like 3 days ago. It's a chronic issue for me. I hate it. It's getting better, but it always teaches me something, and just teaches me respect the human body a little bit more every time it does happen. So
Yeah, I like that breakdown. I mean, I've on this podcast definitely shared my experience with back pain a whole lot. So I'm with you. It sucks, but it definitely gives you a different lens to look at. I think when you're trying to help somebody. I mean, I feel like most of the people that I see are these like long-term issues that kind of pop up over time. But I'm actually curious, with you mentioning the reoccurrence rate at 50%, these ligamentous injuries, people go back too fast. Is there any sort of guidelines that you would put into place so that someone would feel like they would know that they're ready to return back to sport or back to whatever activity they want to do?
yeah, there's a lot of them, and we're currently doing a lot of this at Champion. So I work for the listeners at Champion PT and Performance. It's a sports physical therapy facility, and we kind of pride ourselves in the fact that if you walk into the clinic and you're like a 60-year-old, you might feel out of place because a lot of places that call themselves a sports physical therapy clinic, they'll have mostly geriatrics, which is the most common population that, people need physical therapy services for. So I'm not knocking that, but a lot of places will call themselves a physical therapy facility that specializes in sports, and they really don't. For us, it's the opposite. If you're a normal person and come into our facility, you might feel a little bit uncomfortable. You're like, holy God, like it really is mostly like, let's say like high school, middle school, college professional athletes there, right? So we see a ton of sports. My bosses are pretty well known in the sports physical therapy world. So Mike Reinold was the president of the Sports Academy from the American Physical Therapy Association. He's just transitioning out of that role. Lenny McCreen is also my boss. He's been very active in the sports community for years and years. They publish a lot of research in that realm. And currently, we're trying to update our systems for return to sport. So this is very relevant, And I think if you're really in the sports physical therapy world and work with a lot of athletes, this is probably not groundbreaking news, but we do a lot of return to sport and criteria-based testing, right? I think one of the biggest ones is just doing regular handheld dynamometry. And I think lateral ankle sprain is a little tough because it's tough to measure ankle dorsiflexion, inversion, eversion, plantar flexion. But to bring it back to something more simple, let's say after an ACL reconstruction, you really should be doing this. We have to test someone's knee extension strength and hamstring strength. And we use handheld dynamometry, and we're looking for around 70% LSI or limb symmetry index before we initiate things like plyometrics. We'd like to see around 80 to 90% before returning back to any sort of sport specific drill, right? We're looking close to that 100% before we return back to sport. But we use a lot of different things, right? So it's not just looking at limb symmetry index and strength at the knee. We're also looking at things like rate of force development. We're also looking at torque to make decisions about how we progress over the course of time. We're very blessed. We have a lot of technology. So we use force plates as well. The force plates give us a lot of data about symmetry with jumping. They also give us information about different types of jump. So jumps that have a very short ground contact time versus a longer ground contact time. We want both of those as an athlete. Certain sports need more of one particular type of plyometric versus another. We can assess that. We can see if it's progressing over the course of time. We're just messing around now with something called the 1080 sprint. So we can look at more horizontal jumping and sprinting. We can see how much force people are putting into the ground with every single step, which is amazing. And we can use all of these things to make smarter decisions about when folks are able to return back to sport. So we put a lot of thought and effort into our return to sport testing. We also put a lot of thought into our return to sport protocols. One of the things you'll see in a lot of literature studies is that people have to complete a protocol. So they have to go from systems at Champion that we like to use, and it varies based on the individual. It also varies based on the surgery or the injury that they had. We're going to return a lateral ankle sprain a whole heck of a lot faster than we would an ACL reconstruction, obviously. And the rate at which they return back and they go through the stages is going to be variable depending on how severe the injury is. So if you can't walk after a lateral ankle sprain and there's no fracture, yeah, we're going to go a little more slowly, but we'll start rehab right away. If you do have something where you can start to run on that right away, then you're going to progress much more quickly. Same thing goes for like a hamstring strain injury. You might be able to still run after a hamstring strain injury, or you might not be able to walk. And those are going to have two different timelines in terms of returning. And it really depends on how fast people progress through their stages and how strong they get over the course of time, how fast their range of motion kind of returns. So it's a lot of information. Does that kind of answer that, at least to a degree?
Yeah, and I think it does. One of the things that I was wondering as you were going through a lot of the return to sport protocols that you guys have, and I know how diligent you guys are just from following you on social media and how your thought process all lines up. And one thing you shared when you were talking about picking the right physical therapist, not only somebody that understands what you want to get back to, but maybe is involved in your sport, understands, the grit and the grind that it takes, has gone through injuries in the past. Like it sounds like everybody at Champion probably has, including yourself. So with all the return to sport, jump, plyometric, things like that, I'm sure there's a lot of psychological variables that come into play for an injured athlete. You really made me think about that when you were talking about the suddenness of something like a ligamentous injury versus the buildup of something that you can see kind of coming with that tendinopathy, or, it's getting a little bit more irritable each time. So do you guys have any specific protocols or things that you like to use to help your athletes get that psychological edge, or like help them cope with maybe some of that anxiety, depression, not going back to their sport?
Yeah, I think the big one are just psychological readiness questionnaires. There's a lot of them, and there's some that are specific to like ACL. I can send some over if you guys want after, if the listeners want to take a look at the ones I recommend. But largely, you can give a questionnaire just to see how well they're doing. We do know that folks are often not confident in their ability to return. And I think I've shared this stat on social media, but after ACL reconstruction, only around 30% of athletes will do any sort of plyometric testing before they're kind of discharged for their sport. And my first thought is like, if no one is even doing any sort of jumping in their program, they're not going to feel ready in any way whatsoever. So I think the biggest thing, and I am dumbing down the whole process by saying this, but you really have to do your due diligence as a physical therapist, just progressing them through all the stages, So if you build their strength and then you're testing your athletes and you're giving them an idea of the benchmarks, and they're seeing their strength improve over the course of time, they're seeing themselves hit these benchmarks. You start with easy plyometrics. You see where the deficits are. You're being specific about the exercises. Athletes see that these deficits are going away. You're filming them. You're looking at their movement. They see how their movement wasn't good. They're starting to see how their movement is improving. You take them through more challenging drills, more sport specific drills. You're taking them through drills over the course of time that look just like their sport. You're looking at how fit they are. You're giving them drills that maybe match the sport specific demands from a conditioning perspective. They have the right strength. They have the right power. They have the conditioning. They've been doing this for months and months and months. Their readiness is going to be a whole heck of a lot better than someone that just didn't go through that process. We haven't even done any sort of psychological interventions, right? So I think as a physical therapist, one of the best things you can do is just prepare athletes extremely well. And then I think that what you'll find is that their psychological readiness questionnaires get better and better and better as a result of the PT being better, right? And I think the other part is that sometimes folks have to have their expectations lowered, and this stinks. But if you look at return to sport, like especially for ACL reconstruction, um, and this has been a point of contention recently, just due to a recent study showing that 9-month mark after ACL reconstruction might not be everything, but largely the 9-month mark is important after ACL reconstruction. We have a good amount of research to show that if you delay return to sport up until 9 months, the risk of injury goes down, which is a very good thing. But a lot of folks are not ready until way after 9 months, right? Depending on the study you look at, if you're doing any sort of return to sport battery of testing, a lot of folks aren't ready until month 10, 11, 12, right? So it might take longer than a year. And certainly some folks do get back at 5 months, but a lot of folks, once you get to 9-month mark, their psychological readiness is poor, but they haven't passed the battery of tests to return back yet. They're really not ready, right? So it makes a lot of sense to me that some folks are just going to report they don't feel ready to sport because at that 9-month mark, when they've maybe been told by their surgeon or other folks that they should be ready to return back to sport, they're not. I mean, their performance doesn't reflect that. So Makes sense. They may not feel that way. And I think it's important if an athlete doesn't feel like they're ready to return back to sport, they probably aren't ready unless they do have some sort of true psychological issue where they look amazing and they're well prepared. And if that's the case, a lot of times I just kick the can to another professional. I'll send them to a true sports psychologist that can talk them through this, because there is an extent to how well I can prepare people psychologically. I think as physical therapists, we have to be aware of the importance of psychology. And there are a few things we can do with our skill set. But if you truly have someone that has a problem with things like anxiety, depression, stress is another big one, then I think oftentimes just sending to the right professional is going to be important. And, it's going to increase the patient's outcome, and it's unfair to the patient if you don't do that. So that would be what I would do.
That's fair. I like that. And it just when you just mentioned that 30% of people that don't have any sort of return to sport testing, and it just makes me think every time. I haven't worked with ACLs in a long time because I'm virtual now. But every time I remember with an ACL person, the first time I asked them to jump on their affected leg, there's always hesitation. So imagine never having somebody jump and then saying, all right, like just go back and play soccer or go back and play basketball or something like that. Like they 1000% wouldn't feel ready. So that's interesting.
Blows my mind.
Very interesting stats to me. I don't know if the listeners find the same thing, but
No, I think, and you really bring up a nice point too, Dan, and I appreciated the connection to the objective testing. Because a lot of my clients will always ask me, how do you know I can do this? And I was like, well, your test told me, your special test told me, your force output told me, the fact that you were able to do, 15 single leg squats off the bench told me, the fact that you were able to do that. So I think it is really important for those listening is like to not just be told you're ready to do something, but to actually have it proven to you is so much more valuable. It ties into the story. And I really always see those confidence things go up. And I'm like, look, I don't know if there's a perfect number that's ever going to exist in the literature with like getting your quad back, to this number, and then that prevents the ACL. But I think more and more like reestablishing that trust, not only in their bodies, but in their process, I think is really, really important. So thanks for sharing that connection for us.
Yeah, for sure.
Yeah, no, I think just sticking with the surgical ideas, because I know we've been bringing up now ACL. We're talking about that recovery process. And again, the connection of like, that's a sudden sort of ligamentous thing. I know there's some things popping out now that people can go without surgery and a cross bracing protocol and stuff like that. But my question to you, dealing with all these athletes, is maybe switching gears to the other side of the injury, right? Like these like nagging things that are building up where surgery becomes an option, or a doctor tells one of your athletes, hey, we can go in there and clean this up, whether it's maybe a rotator cuff or maybe some meniscal pathology in the knee. So I was wondering, for you and Champion, are there times where you're looking at an athlete and you're like, yes, go get the surgery, this is going to give you your best chance of your outcomes? And then simultaneously, is there everyone, or are there any processes or procedures that you're like, hey, definitely avoid this one at all costs?
Yeah, this is a good question. And what I will say, in my background as a physical therapist, I was kind of averse to surgery, which I think a lot of physical therapists are. They want to try to heal things with exercise. And I think in a lot of cases, obviously, exercise is warranted. What I will say over the course of my career is a lot of this has flipped, where I am much more open to surgery. And I think a lot of this comes with getting smarter, learning more about different pathologies, learning when it's more appropriate to have a surgery versus not. Also, networking with good surgeons as well, being a little less scared of the process, because some cases you might be spinning an athlete's wheels for months to years, when if you just got the surgery, they'd be back faster. And the thought is like, well, why did we waste so much time doing conservative care? You sold this to me as the right way to go. And there's definitely times where people jump the gun, and that's definitely a problem too. And our knowledge is always changing. I think, a good example would be slap tears. Surgeons are doing less and less slap repairs, particularly for higher level athletes and throwers, in particular pitchers, even more specifically, where we used to do a lot of slap repairs. Now we're finding the outcomes aren't quite as good as just kind of letting them go and hoping they can rehab. But they may get to a point where they're not improving, and then you may need some surgery. Speaking towards injuries that would potentially need surgery right away, I think if you have a traumatic anterior instability, shoulder dislocation, that's one of the big ones, particularly if you're young. So the younger you are, the worse the outcomes are. So if you're like even 11 years old and you have a traumatic dislocation playing football, your likelihood of getting back and not recurring, particularly if you play some sort of impact sport like rugby or football, very slim. You're probably going to have another dislocation, and you keep spinning your wheels. The problem with those dislocations is that when they come out the first time, it's always caused damage. So usually that's a Bankart lesion if it's traumatic anterior instability. As they continue to recur, you can start knocking off bone. So you start taking chunks of the glenoid off. You can also cause an impact fracture, Hill-Sachs lesion to the humeral head. And what can happen is that the surgical intervention is more and more invasive over the course of time to try to correct that. If you knock off enough bone, you can no longer do a Bankart repair, or you can, but the outcomes might not be good. Then you're looking at something like a Latarjet procedure. Now they have to take part of the coracoid onto the glenoid. So it's just one of those things you don't want to let have happen over and over again. There's been a few folks in the UFC world. I'm trying to remember. I'm not going to say anything because I'm going to mess up the person's name, but people end their careers because they have dislocation after dislocation after dislocation. They don't get the surgery, and now they can't come back at all because the shoulder is too messed up, and sometimes it leads to advanced osteoarthritis. This is obviously, it doesn't happen to everyone, and I'm just kind of putting fear into people's minds, but that does happen, right? I've seen that happen in a lot of different joints. I've seen that happen in the hip. So CrossFitters that have a hip tear kind of keep pushing through this over the course of time. They can no longer get the labrum repaired, or they get some osteoarthritis to the point where they can no longer get a hip labral repair surgery. So it does happen in that joint as well. The rotator cuff is another one where it's a bit of a toss up. And I will say that I've become a less conservative person over the course of time. So there's a lot of optimism now in the social media world, I think rightfully so, about rotator cuff tears. Just because if you look at data about rotator cuff tears, even the large or massive ones tend to improve over the course of time with physical therapy. That's a good thing, right? We know that the bigger the tear gets, oftentimes the worse the outcomes are from a rotator cuff repair standpoint. But if you have a younger person with a larger rotator cuff tear, we know that's probably going to progress over the course of time. And the thought is, if you don't repair it, then over the course of time, they may get worse. And then if they decide to get rotator cuff repair eventually, they may not be able to because it's gotten to the point where it's retracted and they can't bring it back, or the retraction is so bad that the outcomes are going to be worse. And I think the folks that would say that, well, look at the data, it looks like you can rehab that. Most of the research on rotator cuff tears are in sedentary individuals. If you have someone who's very, very active that wants to be able to do, let's say, push jerks for the rest of their life, I don't know if the best, option is to treat that conservatively. I think for that individual, you might want to send them back to the surgeon sooner because we know that the rotator cuff repair is going to do decently well. We have some great research that shows that CrossFitters specifically do well with rotator cuff repairs, have really good return to sport rates. I would potentially push them to get surgery a little bit faster, rather than just tell them that like this can be handled conservatively. So time will tell. One of the hard things, and you would think we have this data for the rotator cuff, is that we don't have data to show like, okay, I'm 40 years old. I have a large rotator cuff tear. I get surgery and I want to see how my shoulder is 30 years later, right? Because that's really what I care about. Or I don't get a rotator cuff repair and we'll see how the shoulder looks 30 years later. And I continue doing, let's say, CrossFit or some sort of like intense weightlifting for my shoulder. We don't have that data. And one study that we have from Moose Mayer, it's funny, it's this study I quote all the time and the guy's name is hilarious, but they're 15 years out currently after full thickness rotator cuff tears. They're looking at outcomes for surgical repair versus conservative treatment. And the surgical repair group is outperforming the conservative treatment group at this point. You will have well-controlled trials or 1 or 2 years out showing there's no difference between surgery versus conservative care. But the big thing is like, I want to know what 15, 20, 30 years down the line looks like. That's more important to me. However, these folks aren't doing CrossFit. They aren't doing high level stuff. So I don't know. I don't look at research all day long like a classic researcher PhD does. So I do think this is a nuanced discussion best served by folks that are more experienced with this. But I also, just from reading the research myself, it's not clear to me that one intervention is going to be superior to another. So I would say that it's a coin toss from that perspective. And I guess what I'm getting to is that it's very different from injury to injury and person to person. So it's almost like tough to just say, surgery is good or bad. It really, really depends on the injury and the person, right? And how the rehab goes, just because I've seen folks in the spine, let's use as an example, and I think you'll see a ton of research that shows that conservative is equal or better than things like microdiscectomy and fusion, right? Because those are the scary ones. Are like, oh, I never want my patients to get a fusion surgery. But I've also seen high-level CrossFit athletes or just high-level recreational folks who get fusion surgeries and or microdiscectomies. And they do extremely well. And they return back to sport and they feel really good. I've had folks where they've had disc problems, let's say a disc herniation, and I'm just telling them like, hey, hold out on this, hold out on this. I think you can turn the corner. Eventually they're just like, screw this. I'm going to get surgery because I'm dying. And after the surgery, they feel like $1,000,000, right? So I do think that you have to follow the literature. You have to know the outcomes of these procedures, educate the patient, know when conservative is the right approach, know how long you should try conservative before you decide. But I've definitely kept people in misery longer than they should have. And I think sometimes like spinal fusion surgery is a good example where people are just used to the horror stories, but they never hear any of the success stories. And I have a Rolodex of success stories in my head that I just have to keep in mind. It's like, well, I've seen a lot of folks do really well with this to get back to a high level function where it was a good procedure for them. So yeah, it's gray. It's hard to answer that question.
No, that's 100%. I'm curious because usually, I mean, I'm not working with high level athletes that are, professional level or anything like that. But a lot of times, if the conversation comes up, I tell them it's like you have to weigh risk rewards here, right? And like what we want to kind of get back to. So I'm curious, really, where sure, it's different person to person, but how do you go about like having those conversations with your patients and educating them and helping them make the decision for themselves?
Yeah, I try to tackle it from the get-go. I let them know. Someone comes in, I'd say, good example would be hip labral tears, right? So I've been burned by these over the course of time. I probably have a labral tear in my own hip. I've been dealing with off and on. I've just never gotten any imaging. I just stick my head in the sand and I'm just like praying, hoping for the best. We'll see what happens over the course of time. Do what I say, not as I do kind of thing, right? But we do have some interesting literature on hip labral tears, essentially showing that if you don't get surgery for these, if you wait too long, your outcomes can be worse, right? So some of the algorithms you'll see in research studies is that you trial conservative care for around 3 months. If things are not getting better, we're not starting to improve. And I think there's a difference there. So if someone comes in, their hip is killing them and they have a hip labral tear and you start physical therapy and 3 months later they're improving, I say keep going. It's not like you need to get surgery at this point. Just keep going. But if they're not making any progress at all and are worsening and you've given it 3 months, then you might want to consider surgery because if you don't, then you might be worsening their long-term outcome by not considering it, right? So for that individual, as soon as they come through the door and we diagnose them with hip labral tear, right? I'll say it might not be a bad idea to go see a surgeon if we're not improving over the course of time. Twofold, right? Because I want to make sure that I know what we're dealing with because I might not be accurate with my diagnosis, right? Although I think for hip labral tears and FAI, it's pretty black and white. I think it's not one of those things where you're like, oh, it's just still pretty gray. I don't know what's going on. You can kind of tell if someone has FAI. I think other pathologies can be a little bit confusing, and sometimes you have to send back to the doc to get some imaging to see what's going on. I think FAI is a little bit more clear. I'll let them know, like, let's say 4 to 6 weeks you're not improving. Let's go set you up an appointment with a local hip surgeon. And we're lucky. We have a lot of good surgeons in our network. So I know that I'm not sending to someone who's going to jump the gun and just say, let's do surgery right away. But I know at least for them, if we don't consider surgery soon enough, then we might end up doing a disservice to them. And the other piece is that doing a corticosteroid injection into the hip can be very helpful in the rehab journey. So if I'm not sending back to the doctor, and there's other diagnoses that are similar to this, I think frozen shoulder is another like obvious example. They need additional interventions with physical therapy oftentimes. So if I don't send them back to the doctor and I don't like suggest that a corticosteroid might be helpful, I may really reduce the ability for them to heal over the course of time. So I just let them know from the get-go, I think this is what's going on. Most of these, and I'll pull some stats, right? I'll say, I try to be very hopeful and say, oh, okay, 8 out of 10 folks with FAI gets better over the course of time, right? I just take this data straight from studies I've read. Around 2 out of 10 of those folks will need a corticosteroid injection, right? And then about 50% of those folks who do really well with the injection won't need surgery. And around 10% of those folks will go on to get surgery long term, right? So I let them know from the get-go. And here's the other piece. I mean, for my own hip, I started with some FAI symptoms like 8 years ago, 10 years ago, and my symptoms have been up off and on for years, right? Now I'm in a really good place. I very rarely feel my hip. It doesn't give me much trouble, right? And maybe I'm destined for arthritis. I don't know. But like that 3-month mark, I often feel like is not enough time for a lot of folks. And you can let it go for longer. But it's just important that you understand that we do have research that shows if you delay too long, that's also a problem. So I try to educate people as much as possible from the get go. And I try to remove myself a little bit from the decision making process. I'll let the patient try to sort that out themselves, but at least I give them the information to make their own decision. I feel very strongly at the end of the day that we're a service-based industry. I want to serve people as best I can. So I want to give them the best data that I can to make their own decision, right? I put the power in those hands. I don't want to push them either direction. But if I think that they need to know, like, hey, if we wait too long, you might not do as well, that's important because I personally would be pissed off if a physical therapist never told me, like, oh, yeah, you had a labral tear. And yes, there's data that shows you way too long. That's a problem. Because if you spin your wheels for years and years, and then, again, I've been practicing for long enough where I've been burned, where I have a patient that has FAI, they go and get some imaging, have a labral tear. And they're like, I'm going to try to treat this conservatively. They go too long, and essentially they lose joint space. And that's not what happens to everyone, but some folks it does. Now they can't get labral repair because they have too little joint space, and no surgeon's going to do that surgery anymore because the outcomes aren't great. Now they're staring down the barrel of a joint replacement surgery, and they might be 40 or 50 years. And now your long-term outcome is like, I don't know, like we might have to have multiple revisions now. We may have set you up for failure. And I've seen enough of those folks over the course of time. And human beings are funny because when you see one of those, now it's like taints your whole vision. Because you're like, oh no, I don't want this person to have like advanced hip osteoarthritis. It's not the normal, but as a human being, like that sticks out in your mind. And we still have to, just keep in mind a large majority of folks are fine and that's not going to happen. But it does happen. So I think that we just need to be level-headed and then give people the data to make the decision. I personally feel in some ways social media has made us a little bit weak, right? It's almost like, I hate this, right? I think that people should get all the data to be able to make their own decision. I dislike when physical therapists don't give patients an idea of what they think the diagnosis is because they're afraid of scaring that individual. I try to educate people on the diagnosis as much as I feel like I can because we know that it's really hard to give someone an accurate diagnosis, particularly for like the spine, for example. But I think it's our job to give them a diagnosis, particularly if they ask for it. A lot of patients really want that, and they're not getting that from physical therapists. And then you have to do a good job of reducing that fear, right? Because we know that when you tell someone like disc herniation or nerve, sometimes it gets people really fearful. And I'll ask folks, I'll say, hey, have you gone down that rabbit hole of learning what a disc injury is or a nerve injury? Because sometimes the only knowledge someone has is like, and I always say this in my courses, you may have heard this before, like Uncle Larry got disc herniation when he was 22. Every time we go Thanksgiving dinner, I got to sit next to Uncle Larry. Uncle Larry's always pissed off because his back is hurt for the past 30 years, right? You got a spinal fusion. And ever since then, you can't sit down for more than 5 minutes. And he's like the biggest grumpster in the world. And if you hear that you have a disc herniation, now all of a sudden you think you have Larry's trajectory, right? So I do think it's important that we ask some questions about what folks believe about their pathologies, and then just give them really solid education. The very first thing I'll say after I tell someone I think they have a disc injury is like, hey man, these can heal just like anything else, right? Because if they don't have that knowledge, but they have prior information that scares them, they might be going down a dark path that's not so good. So I think that we do our best job of diagnosing and then decreasing any fear, anxiety surrounding that.
I like how you broke that down. I'm curious, with all of that information that you just said, like giving something some time and seeing if it gets better. If not, then, making some decisions from there. Not everyone's going to see a Dan Pope or Joe LaVacca. So if we're looking at like the physical therapy, even just rehab as a whole, how can people really kind of know if they're getting good care? What is the added benefit of seeing someone like yourself? How can people, almost like be an advocate for themselves in a sense when they just go to the closest place to them that insurance takes?
Yeah. So what I will say, and I kind of hate when people do this, I think physical therapists are very well educated. And I think we're a little biased at Champion. We get a lot of smart students that really want to become good physical therapists. So I'm a little bit biased there, but I think the quality of physical therapists, at least that I see, particularly students, it's very high, right? So one of the biggest things that I get question-wise because I have an online educational business, and I really try to target coaches and clinicians, but inevitably, I get a lot of folks that comment towards me and say, "Oh, I tore my labrum," or "I have a meniscus injury. Is what I'm doing appropriate, right? What should I do?" And I'm almost always just trying to push people to see a physical therapist, see somebody, because we're pretty good, man. We get a lot of education. If anything, we're overeducated. So I think the standard is actually pretty darn good, right? So I think step one is like, go see a physical therapist. And I think oftentimes when people come out and they complain about the physical therapy they've gotten, it's because maybe the physical therapist didn't establish good rapport, or maybe the person was skeptical and didn't believe what the physical therapist had to say. Because sometimes when I dig into what some folks that tell me that physical therapy didn't work, they just didn't listen to the therapist. They didn't believe them. They didn't try this stuff, right? How many times have we seen that, right? But what I would also say is that I do think it's important as a consumer to find a physical therapist who at least understands what you want to get back to, right? I mean, if someone comes to me, I just had this the other day. So I have a powerlifter patient of mine, and she really trusts me, and she's referred a lot of patients back to me. And it's a lot of folks that like powerlifting. I have a lot of experience there. Been treating those folks for a year. I feel like I have a good handle on it. And she's like, my friend has a 13-year-old daughter. She felt a pop in her hip when she was doing a split, right? And I was like, yeah, I think I could help her out. But I have a coworker, his name's Dave Tilley, and he's like, speaks nationally in terms of rehabilitation for gymnasts and dancers, right? And I was like, you should go see him. And the first thing I told Dave, I was like, I have this patient of mine who has a friend whose daughter felt a pop in the back of her hip when she was doing a split, right? And Dave's like, oh yeah, it might have been like a growth plate injury to the rectus femoris. And I was like, I would have misdiagnosed that because he sees those all the dang time, right? So it would, if she came to see me, like I would probably like, it seems like maybe the rectus femoris. I don't know if there's like a tendinopathy there, and maybe I would get around to it. But if he goes and see Dave, Dave is like, oh yeah, that's what happened. Here's the next steps. Here's what you should expect. He's extremely good with that. So it just like cuts a lot of steps out of the rehab process. And maybe I'd be able to struggle through that and get her to where she needs to be and rehab it. But for someone like Dave, it's like, it's his bread and butter. You know what I mean? So seeing someone who understands your sport is just super helpful. They get it. They understand it. They know the nuances of it. It's like having just like cheat codes, right, to success for those patients. So I do think that you go into a clinic and then you just, you look around, you see what they're doing. You can ask questions, say, hey, do you guys have experience working with baseball players? Do you have experience working with lacrosse or whatever sport it is? And, hopefully the clinic doesn't just lie to you. You know what I mean? Because I think as physical therapists, we have to understand our limitations as well. I refer out a lot. I have no problem with it. If someone has a question, I'm like, oh, this seems like it's pelvic, pregnancy, postpartum, or like pelvic floor oriented. We have a good network of those folks. And like if I'm trying to like treat those, like we have a good network of certified hand therapists, folks that are really good at the foot. We refer out. I want to make sure that the patient is served well, and I think that just it makes our community stronger, right? If a patient can go to a clinic and the clinic can say, hey, you've got something very well served by, Joe down the street, and then they go to Joe and they have a good experience. And I think there'd be less people on YouTube saying like, I had a bad experience with my physical therapist. You know what I mean? So I don't know. I think about that a lot. We're trying to elevate the standard of our care. And sometimes you're in a place where maybe there's no local physical therapist that can do it. But as a consumer, I do think you have to do a little due diligence, call the clinic up, see if they have any experience, drive by the facility, see if they actually have, this is particularly important for sports, right? Do they have the equipment that you need? Do they have like a little space, a little bit of turf? They have experience working with those folks. You can kind of dig into that and see.
That's Dan, the one thing that I keep hearing, and I think it shows in your social media, I think it shows in your educational content, just helping people make the best decision together. So I really value that. I really respect that. I really think that's an important message that people should probably pull from listening, and I think they are. So I just wanted to say thank you for advancing the profession forward in that way. The other way you would advance the profession recently, my friend, was writing a book with another gentleman that I highly respect, Mr. Dean Somerset, called Rock Solid I was hoping you'd flash it for us. There it is. Beautiful. Love that cover. Nice and shiny. Look at that.
Joe, we
So
should
the
be
book is
waiting for our
called-
signed copy to come now.
Yeah, well, I'll wait. I'll be standing by the mailbox. The book's called Rock Solid Resilience. I wanted to give you a couple minutes to speak about it and maybe share What was the most surprising thing you learned in that process? Because I'm watching my fiance Courtney write a book, and I am just blown away by how much work goes into these things and how much detail oriented like certain things have to be. So share a little bit about that, if you will, and what'd you take from it?
Yeah, the book writing process was very interesting. And just give you a little background of, my history of creating content. Like I've been creating content since like 2008, right? I've made like 30 to 40 courses over the course of time. I've written a ton of like ebooks. I've done a ton of self-publishing, right? I'm creating content all the time. So making a book was in some ways natural and in some ways not. This is the first time that I've ever been able to work with a publisher. We worked with Human Kinetics, which is really cool. And it was a neat kind of experience for me. It was a kind of interesting way that I was even recommended for it. So my co-author, Dean Somerset, I believe he was approached by Human Kinetics and he always wanted to write a book. And they wanted to do some sort of book that revolved around kind of lifelong health with, and they also wanted to have some sort of physical therapist as a co-author just to increase the authority, but also help people from an injury management standpoint. And Dean asked around a little bit, and I don't know if you guys have heard of Tony Gentilcore. He's like
For
another
sure.
kind of popular online trainer, but I'm buddies with Tony, and Tony recommended me, which was interesting because I like Tony and I've been following Dean for years, but I never met him. Right. And it was funny because I feel like I knew him. If you ever read any of his social media content now, but his articles back in the day, he's very, very friendly and personable. And when I first talked to him, I was like, I feel like I already know this guy. I feel like I've been like, because I've been reading his stuff for years and years and years. And I feel like we kind of grew together. We're kind of similar age and we've been kind of creating content for around the same period of time. So that was cool. And then writing the book was, I don't want to say easy, but very natural. And it was a little bit different for me because the typical avatar that I write towards and kind of try to speak towards are coaches and clinicians. And this book was made more towards the average consumer that just wants to strength train, kind of lifelong healthy, which is my entire brand. But usually I'm speaking more to the clinical person, right? So that was a little bit different. And it was fun because you can talk in the same language that you use for your patients all day long. I tried to actually use a style that's similar to Dean, which he makes a lot of jokes when he writes. And that was actually a lot of fun for me. The thing I wasn't prepared for was just how long this actually took. So I want to say it was almost 2 years from start to finish. And we actually finished the book. And I want to say like 4 to 6 months, right? So this thing was completely done from a writing perspective within 4 to 6 months. And then the next like year and a half was all based around editing, photo shooting, waiting for deadlines to occur, right? Fine tuning, marketing, everything else. And from my perspective, I'm used to like, made a course, turn it around, do it fast. And I think I probably published like 7 to 8 courses in the time period where I started writing to when the book was published. So on the back end, I was like cranking out stuff while this slow moving behemoth was like being born, right? And that was one of the things that surprised me most. So I even like some of the references because I deep dive on like literature before I do a lot of my content as well as like some of my courses. Like some of that stuff's like a year and a half old and it's potentially has changed and evolved since then just because like the lit review happened a while ago, but it's a brand new book. So just makes me laugh. But that was probably the most interesting difference is just kind of like how long and arduous the process was. It wasn't bad. It was just slow moving.
Is there something you're hoping now that you wrote to a different audience, right? The consumer. Is there one thing that you're really hoping that they take from the book after they read it?
Yeah, I don't know. I think one of the things I feel kind of strongly about is that coaches and trainers and even the individual. So two things. I think coaches should have education about how to manage pain with their clientele because they're basically going to see it every single day of the week. And for whatever reason, physical therapists and healthcare providers have a monopoly on pain. Like, if you have pain, you should see a doctor. Personal trainers shouldn't try to manage this in any way. And I think in a lot of ways that's important. There's a medical red flag. If someone's like pooping and peeing in their pants and they come in with low back pain, they need to go to the emergency room, right? You're not going to like, oh, well, let's try to squat today. Like that's not a good idea, obviously. So I do think that we need to be smart about what we do, as a coach. So putting my coach hat on and making sure that you're not trying to be a doctor or physical therapist. But on the flip side, it's like your clientele is going to be dealing with orthopedic issues every single day of the week. You need to know how to manage that to a degree. And I feel very strongly that coaches should learn how to do that. And the other thing, and this goes for so many other industries as well, the amount of misinformation out there, the consumer has to basically just try their best to guess and kind of work their way through to find the truth it's so hard. It's so hard. I find myself having this issue too. Like, I don't know. I'm trying to like get my lawn better right now, right? And I'm getting into it. And there's so many contrary opinions out there. They're like, "Oh, put the grass seed down here." No, don't do it now. You should have done 2 weeks ago. And here's the reason why. And this guy's stupid because he's putting his grass seed down now. No, this guy's stupid because he's putting his grass seed down now. And I'm like, I don't know what to do. What do I do? When do I put my grass seed down? And that's what's going on with a pain problem. So someone's knee hurts, they're going on Instagram, and like one person's guy is like, knees over toes. And then Joel Siebman's like, do not bend your knee. That's going to blow that knee apart, right? And I think the consumer is just so dang confused. They don't know what to do. And that's really unfair. So I think that what I really tried to do and Dean tried to do is just give some sort of like level, gray thought process, decision-making process that takes into account what we know from an evidence perspective and helps people figure out a way that they can manage their own orthopedic injuries, know when they need to go see a doctor, know when they can just kind of train with this and make some smarter decisions, because there's a ton of misinformation. It's hard. The problem is that that's not good from a marketing perspective, right? What Knees Over Toes guy does and what Joel Siebman does is great for marketing because they think in absolutes and people like that. It's kind of a black and white thing. It's very polarizing. It's sexy. But if you try to give something that's nuanced, it's not that popular. And you don't sell many books, right? But it's also probably way more accurate. So that's one of the things we try to do. And maybe we won't become as popular, but if enough people do this, maybe someone cracks, the code and they'll get out there and help more folks. So I think that's, what we try to do at the end of the day is give something that's accurate, help more people, put the power in their own hands, and give something that's nuanced.
Well, you got two fans here, my friend. We'll be picking up the book for sure.
I was just gonna say you get the Cups of Joe stamp of approval. So
Oh, nice. Yeah.
yes, it's the first one ever given, so it's a high honor.
Yeah, it's very, very, very high, very high.
Regards. I like that. Yeah.
Mr. Joe, do you have, I want to be respectful of Dan's time. Dan, you've been very generous with us. Do you have any other closing thoughts or questions for Mr. Dan here?
I do not.
All
I
right.
do appreciate your time, though, Dan.
Yeah, thank
Dan,
you, guys.
thank you
I really
so much.
appreciate you guys having me on here. I had a blast. So appreciate what you guys are doing for the industry and for folks like me. So thank you very much.
Appreciate you, man. We'll definitely have you on for the second book. I'm sure you'll just be cranking them out now that you got it going. But yeah, man, no, this is great. I think there's a lot of value here for clinicians and patients alike. So we appreciate your thoughts. Joe, love you. Dan, love you. Listeners, we love you. And don't forget to come back next week for another exciting episode of the Beyond Pain podcast.